here to start gather here to valuable lecture regarding the trauma care for nurses. I warmly welcome Dr. Chaminda Sandaruwan, acting consultant in emergency physician. He is one of my colleagues in medical intensive care unit Apeksha Hospital, Mahanagama. And I would like to warmly welcome all the nurses joining here. And I respectively invite Dr. Chaminda Sandaruwan. Over to you, Dr. Chaminda Sandaruwan.
Okay, thank you much, Shankar. So, as Shankar introduced me, so we were like friends for years while we were working at ICU Maharagama. So since then, we did several lectures and discussions, practical sessions. So after coming here to like UK, so he asked me to like discuss on trauma care. So this is a vast topic, but I'll try to limit the things that important to you. And actually, it's better to join you either like ALS or the other resuscitation courses and trauma courses conducted by the College of Surgeons. So this will be only a guide to you to like you need hands-on skill later that. So during this, like actually this is not a lecture, so this is a discussion. You can ask anything and you can leave your like views, questions in the chat box, or straight away you can ask. So it's like free to discuss anything, and you can raise any concern during the lecture. Okay, so overview of this discussion. So firstly, I'm discussing about the trauma burden, how this trauma causing the damage to our healthcare system and our economy, and then the most of the content regarding the systematic approach to trauma management. So even though most of you are in background of the intensive care, so this initial management it's very helpful to continue your ITU or the ICU care. And finally, I'll be having a case discussion. So you can contribute, and so at any time, feel free to ask any question. So discussing about the global injury mortality. So actually it's a real burden. So 1.25 million people are killed each year. Out of those, like road traffic accidents contribute 30 to 80% of trauma admission in low income and middle income countries like ours. So when you consider the trauma pattern, so road traffic accidents cause nearly 1/4 of the injuries. And when it comes to our setup, so it's a like healthcare crisis, as you all may know. So there's a recent 85% increase in the RTA, and it accounts about 25,000 injuries annually and nearly 10 deaths. So this is to have a rough idea how trauma is important in our setup. And the most important thing is only 52% arrive within the 2 hours after the injury. So they are missing the golden 1 hour, but so it's actually not the 1 hour. We are considering golden 15 minutes. So with rather than 1 hour, our main aim is to stabilize the patient within 15 minutes. And the classic trimodal distribution of the trauma death. So there are 3 waves, as you all aware. This yellow one is within 1 hour. So you can imagine the treatment during 1 hour. But now, of course, we are going in our EDs. It's the golden 15 minutes because the 1 hour that goes in most of the depth. And one more thing, in trauma, delaying blood transfusion in major bleeds. Actually, a 1 minute delay causes 5% mortality. So I think you can imagine how fast we should act in trauma management. And as I told you, it's not the 1 hour, it's now immediate 15 minutes. So these are rough things that we have to do within 15 minutes. Now we have now narrowed down this 1 hour to 15 minutes. So these are the things that usually in our emergency department, we are performing these things to in our primary survey. So main thing is to remember that it's not the 1 hour. Now it's like limited to do the life-saving things within 15 minutes. Again, trauma management. So actually it's a story of successful team effort. So without a good and helpful and trauma team, so there's no success trauma management. And other than the pre-arranged trauma team, there should be a systematic approach for the trauma management. So these are the two criteria: the successful team and the systematic approach. Okay, as I mentioned earlier, it's a teamwork, consists of in-hospital care. In our case, it's 1990. And the in-hospital emergency department. So nomenclature, like sometimes it's emergency department or accident service. So in some hospital, it's preliminary care unit. So whatever the term is used, it's the in-hospital team. And once we have stabilized the patient, so following primary survey, either we transfer the patient to the ITU, HDU, or the latter part is the rehabilitation. So this is the flow of trauma management. I think you're all aware regarding this flow. So most of you are, I think, working and attached to these departments, but it's like very important to know the pre-hospital and the in-hospital emergency department care when the trauma patient is arrived. And two main things to remember. So trauma patient die mainly due to two causes. One is airway compromise, and second one is the major hemorrhage. So these two are the major killers of the trauma, and they're actually preventable if we are protect the airway and activate the massive transfusion. So those two can prevent the deaths in trauma. So let's discuss the pathophysiology. So there's thing called trauma triad of death. These are the three things that cause in the death in a trauma patient. So it's like short mnemonic is HAC. So hypothermia, acidosis, and coagulatory defects. So in pathophysiology, when you are discussing the pathophysiology, so these are the three reasons that causing the death in a trauma patient. So initially, the blood due to trauma itself, the protein pathway, the protein cascade is altered, and so this the altered coagulation itself causes more bleeding, and then the hypoxia and the hypovolemia that causes acidosis. And on top of that, patients are exposed to hypothermia. Together, that these three things together cause for the trauma death. And our main aim is to prevent those things. So correct the coagulopathy and correct the acidosis and prevent hypothermia. So these are the pathophysiological basis in trauma management. And one more thing, who's aware about the shock index? Anybody? I don't have the names. So, are you aware about the shock index? Anybody? Shock index is an important indicator. So it is, I think by now you should all know this one because it's a it's a favorite thing in emergency department. So it's basically it's a simple index. So heart rate divided by systolic blood pressure. So normally it's less than 0.7. So assume that in a shock patient, heart rate is around 130 and systolic blood pressure is 60.
Sandaruwan, can you please unmute your mic? Excuse me, Dr. Sandaruwan, can you please unmute your mic?
So I would. Is that okay?
Okay, doctor, okay.
එතකොට මේ වෙනකම් මත්සන්ගේ ඇහුන්නේ නැද්ද?
ඇහුණ doctor, හරි. දැන් හරි.
So anybody else? So anybody aware about the shock index?
No, doctor.
Any comment? So it's like can you hold here?
Yeah, we can hear you, doctor.
Okay. So anybody aware about the shock index? So this I'm repeatedly telling this is an important index where we use this in the emergency department. So it's simple measure. It's like heart rate divided by systolic blood pressure. Why it is important? So if it is more than 1, it's more predictor to get the signs of shock. So if the shock index is more than 1, it predicts there's a occult shock. And then the so let me go to the previous slide again. So if the shock index is more than 1, it predicts the shock and also post-intubation hypotension. So patient with shock index more than 1, can go to hypotension once we have performed the intubation. And also it is a trigger for the blood transfusion. And the other most important thing is it indicates the severity and the mortality of a trauma patient. So it's better to know and keep in your mind the shock index. Now it's like commonly used in our emergency department. So all I have discussed up to now are the basics of trauma rather than going for the systematic approach for a trauma. So basic pathophysiological basis and the trauma burden. So do you have any questions up to now? So next. Okay, there's no question. So we'll go for a like short video clip. How do we manage ED patients? And then we'll come to our proper topic, the systematic management of the trauma patient. So I'll stop there. So that is they get the usually in a trauma patient with the pre-hospital care, when they encounter a trauma, they page into the emergency department. So that is like pre-hospital information we get before coming the patient to our hospital. Think so. So you can. So here once the unit is paged, that's informed by the pre-hospital. So it's like systematic information is given to the hospital. So do you know any mnemonic that the information is delivered to the hospital by the pre-hospital team? So in this scenario, the information is given to the doctor through the ambulance pre-hospital crew. And so then as you all know, the pre-hospital information is very important. So there's a mnemonic, as you may all know, ATMIST. So the ambulance crew has informed the information, the age, 60-year-old, and the time, at what time that the trauma has occurred, and then the mechanism of injury. So these are very important information to the hospital team to get the preparation for the trauma. So let us again go through the rest of the. So the emergency doctor has identified this is a severely injured patient. So that is an important thing to activate the trauma call. So activate the trauma call. It's really necessary that there should be a major trauma patient, and you should inform the relevant specialties to the trauma patient.
She had a chance to survive. My other thought was, given her age and severity of her injuries, those chances were small, which meant that
Okay, up to now, can anyone you tell the important things you have noticed during this case management? So either you can put into chat box or you can speak up. Matsankar? So any
They give a priority for ARV management.
so that's that. So like just to have an idea how the systematic approach is important in trauma management. So next, shall we come to the our other discussion? Okay. So trauma resuscitation, actually it's a sequence. So these are the main steps of the trauma resuscitation. So preparation, triage. So these two are being done before the patient arrived the emergency department. And as you all may know, primary survey. So that is to identify the life-threatening injuries. So we'll discuss gradually what are the life-threatening injuries we should identify during the primary survey. And then the adjunct of the primary survey. So then once we have achieved the primary survey, then and there we have to consider whether patient required transfer to a specialty care unit. So that is to escalate the trauma care. And if the patient's like following primary survey stable, then we go ahead with the secondary survey, which is content of head-to-toe evaluation. And then this adjunct to the secondary survey. Once the secondary survey is finished, so progressive reassessment should be there and continued post-resuscitation care. So that's the place where we need your support in the ICU, the ITU, or sometimes it's HDU. So once the patient is stabilized and for the monitoring and further care, we do transfer them either to the special care units or then for the definitive care units. Okay, so preparation for trauma. So it's important part of the trauma management. So team assemble. So in our emergency department, we do have a team leader and he's taking the responsibility, and he before arriving the trauma, we should identify themselves and allocate roles. It's important. So, and then identify this trauma as a major trauma. So then we can prepare ourselves to take the prepare the massive transfusion and equipments and drugs So these are the preparation events of the trauma. So team leader is the one who's responsible, and before taking the patient to the emergency department, these are important to successful management of the patient, trauma patient. So we declare the code red, and sometimes it's code blue. So it's differ center to center. And once we have coded the patient, the leader do the team briefing and role allocation and prepare the equipments and other drugs and make the emergency department ready to acquire the patient. And as we have discussed earlier, so patient handovering, so the trauma, as I said, it should be a systematic approach. There should be a systematic approach. So while handing over the patient, so if we use these guide, it's like we don't miss anything. So it's at missed. So age, the time of injury, mechanism of injury, and the injury sustained. And S mean the signs and symptoms. So what are the like while transferring the patient's blood pressure. So one thing is to remember the lowest blood pressure. If the systolic blood pressure is less than 90, it's also an indicator of poor outcome of the trauma and the necessity for the blood transfusion and the treatment given. So this is an systematic approach while we are handovering the patient to the emergency department. So when we discuss the preparation, so as I told you, it's a pre-hospital phase and the hospital phase, and then the triage. Triage, it so depend on the number of casualties. So if it is a mass casualty or multiple casualty, so triage system is varied. So we differentiate the patients according to their injury severity. So then we come to the primary survey. So before coming to primary survey, do you have any questions? Or anything to clarify? It's better raise your questions and chat what are the things. Yeah, Taranga, yeah, I think she has commented regarding that late previous video. Yeah, the assessed patient according to ABC. Yeah, I think yeah that's Taranga want to comment about that the scenario. So any other things you to clarify before we are going for the definitive care? Okay, when you're if you feel boring or exhausting, just let me know. So it's a trauma management. Usually it should be practical session, but let's hope that you are all practicing once you follow this one. Okay, so primary survey. Can anybody tell the aim of the primary survey? What is the main target of doing the primary survey? So it's to identify the life-threatening injuries. So what are the life-threatening injuries? So there are 6 life-threatening injuries that we should identify in the primary survey. So it's also again a systematic approach. So now the trauma management is CABC instead of ABC, C comes. So C is control of the catastrophic hemorrhage, the major hemorrhage. So in a trauma patient, if there is catastrophic bleeding, hemorrhage, so then okay, sorry. Sorry about that. And the catastrophic bleeding, it comes first when you encounter a trauma patient. You should immediately respond for if there's obvious catastrophic bleeding. And so, what are the sites of bleeding you may encounter? So it's abdominal, thoracic, abdominal bleeding, pelvic bleeding, and retroperitoneal, and the other bleeding sites like on the floor. So patient has bled onto the floor. So those are the sites of bleeding. We should the sites of bleeding we should keep in our mind, and we have to take measures to stop the catastrophic bleeding. And once the bleeding, the catastrophic bleeding is controlled, then we go for the airway C-spine, and then the breathing and the circulation. So airway, if there's imminent or the obvious threat to airway, we do intubate with taking cervical spine cautions. And breathing, we do the systematic assessment, respiratory rate, and the respiratory rate and the percussion note, air entry, and the tracheal position, and then breathe the saturation. And if there's immediate threat to the airway or the breathing, so airway, it's like upper airway obstruction, trauma, maxillofacial trauma, or in foreign body impaction. Those are the things that can damage the airway. Breathing wise, it's tension pneumothorax and massive pneumothorax. Those are the two main life-threatening causes that we can identify the breathing assessment. And circulation, so it's not a vertical, it's a horizontal management. So while you are assessing, you do the resuscitation also. So while you are assessing the circulation, you put 2 large bore IV cannulas. And if we are failing IV access, we go for the IO access. And monitoring wise, heart rate, blood pressure, and capillary refilling time. So in the circulation, if the patient is hypovolemic, we can give up to 1 liter of crystalloid and not more than that. I think you all may aware why we are not giving crystalloids. So initially we mentioned that death from the trauma is via the 3 killers, that is hypovolemia, hypothermia, acidosis, and coagulation. So if we overload with crystalloids, so it causes dilutional coagulopathy. So it dilutes the blood and more, it worsens the coagulopathy. And so it's ideal to give blood instead of crystalloids, but we can take time, and it's allowed 1 liter of crystalloids until we get the blood. Okay, so airway, we discussed breathing and circulation. The other one is the disability. So disability, the neurological state of the patient. So either we assess AVPU or the GCS. So GCS is more like reproducible. So what is the importance of assessing GCS, and what is the critical level of the GCS when we can to have a decision to make? So can anybody tell? So what is the cutoff point of the GCS which we consider an urgent intervention?
GCS 7, doctor.
Why? Can you explain? Very good. I'll make it like this is 8. Okay. So 8 by below 8, patient can't maintain his airway. So airway reflexes are obtunded. So in that case, so we have to consider urgent intubation and airway secure. We have to secure the airway. So that's a cutoff point. And pupils, yes, it's the pupil response is important. So we can guide the identification of the intracranial injury. So it's important to monitor and note the pupil size and blood sugar. So disability completed, and so make sure that while you are assessing ABC, if there's any defect, if you identify any desaturation or evidence of tension pneumothorax, you should do intervention and go back to the airway assessment and then come along the pathway. And then exposure, we have to expose the patient fully. As you saw in that video, the crew is completely removing the cloth. It's important to detect any hidden injury, and also make sure that you are not exposing the patient to hypothermia. Like, it's important, as I told, that trauma death is due to 3 main killers, that is hypothermia, acidosis, and coagulation. So hypothermia you should prevent at any cost. And once you finish the exposure, then you do the log roll to see the back of the patient and identify the other injuries. So when we discuss our case discussion, you can identify how important this log rolling is. So these are the components of primary survey: airway, breathing, circulation, and disability exposure. And once you finish the primary survey, there are adjuncts, the helpful things to complete the primary survey. So those are you can take as the imaging. There's a trauma imaging, chest X-ray, pelvis, and bedside ultrasound. We call it fast scan, focus assessment, sonography in trauma. So fast means focus assessment, sonography in trauma. So it's very helpful. And the trauma imaging, chest, pelvis. And then the drug wise, you have to consider the most important thing is tranexamic acid. So tranexamic should be there, and antibiotics, analgesia. And investigation wise, the blood grouping and cross match, BBG, and full blood count, urea electrolytes. So then the tubes, so indwelling catheters, urinary, and if necessary, NG. So once you finish the primary survey and you have stabilized the patient, you go for the ample history. So can anybody tell the component of ample history? So it's allergy, medication, past history, last meal, and events leading to this trauma. So this is an important thing. So all we have, all the way we have managed the trauma, and we don't know the patient is allergic to penicillin, and we have given either cefuroxime or the augmentin. So patient develop an anaphylactic shock. So it's important not to miss any of these components. And these, like, when you keep on practicing, so you can master on these things. So what are the life-threatening injuries in the primary survey that we should identify and correct? So airway obstruction, either due to direct maxillofacial damage or obstruction via the foreign body, maybe edematous tongue or denture impaction. So then the breathing wise, tension pneumothorax and open pneumothorax. So tension pneumothorax, if you identify it, you should immediately do the needle thoracocentesis followed by IC tube insertion. Open pneumothorax, same. Massive hemothorax, So again, the ICU tube placement, and immediately if it is the blood, if the blood volume is more than 400 ml, 200 ml per hour, so you should call for the thoracic team. And initially, earlier in our ATLS, they have not included this one. So instead of the tracheobronchial injury, it's inserted currently, newly. Earlier it was like flail chest. Now flail chest is no more there in the life-threatening injuries in the primary survey. And the last one is cardiac tamponade. So these are the life-threatening and imminent life-threatening causes that we should identify and treat, and then again reassess the patient during our primary survey. So remember this mnemonic, ATOM TC. So airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, tracheobronchial injury. This is newly included instead of flail chest and cardiac tamponade. And always make sure that the patient's volume status are corrected with blood, not by crystalloid, and prevent the hypothermia at any cost. So some of the interventions, again, to solidify this knowledge. So in the primary survey, if it is an amputated limb and if there's bleeding, so we can stop the bleeding by applying a tourniquet. And if there's impending airway obstruction, so we have to do the rapid sequence induction with cervical spine control. So now it's the current nomenclature is cervical spinal motion restriction. That is earlier it has been called as manual inline stabilization. Now it's cervical spine motion restriction, CSMR. And if there's a ventilator failure, breathing difficulty, so either chest decompression via the thoracostomy and chest drain insertion. The circulation is very important to assess the if the patient is hypolimic, hypotensive, and shock index is more than 1, consider pelvic fracture and apply pelvic binder. So anybody has like experience in applying pelvic binder? And can anybody tell me what are the anatomical points? So if you don't speak, I will keep on speaking, and so there won't be any interaction. Okay, so pelvic binder, it's you should apply to the iliac spines, and it's the trochanteric binding. So it's over the greater trochanterus, you should apply it and approximate. And there are commercial prepared pelvic binders. We usually use the and the bed sheet we but there are commercially prepared pelvic bind. And in the disability, as we all discussed, it's like if GCS 8 or less, 8, the problem is patient can't maintain his airway, upper airway reflexes are obtunded. So we go for the intubation. Again, keep on reassessing the patient. So if the catastrophic bleeding is controlled, again, reassess the patient. And if airway, if there's tension pneumothorax, open pneumothorax, after putting the IC tube, again reassess. So, and again, massive transfusion if there's a major hemorrhage, and you should activate the massive transfusion and then reassess. So always once you do a procedure, you again go for the initial steps and reassess the patient. It's important during the primary survey. Adjunct, we discuss and make sure that you log roll the patient, turn the patient back. And it's like, as I mentioned, it's a teamwork. You need at least 4 people to do the log rolling and monitoring, ECG, entitled carbon dioxide, and investigation. So you do the VBG, and again, once you transfuse or the you do like interventions, you reassess, and imaging. So trauma imaging, it's like chest X-ray, pelvic X-ray, and if available, you go for the CT straight. And treatment-wise, transmic, it's important. So within first hour, it's like indicated in major trauma. So dose is 15 milligram per kg. And it is like crash 2 trial is there to give the evidence, and antibiotics, analgesics, calcium, and tetanus toxoid. So why calcium? Anybody? Yeah. Tell me why we need calcium chloride or calcium gluconate. Okay, this is to like prevent when if you activated the massive transfusion, there's hypocalcemia, risk of hypocalcemia. In the massive transfusion activate growth, we have to give calcium chloride and the tetanus toxoid. So once you have completed the initial primary survey and resuscitation, so you have to make a decision whether to transfer the patient for advanced trauma center, if the patient is requiring neurosurgery or like thoracic surgery. So you discuss with the trauma center and straight away we transfer the patient. Or else, if the facilities are available, the same unit operating theater and the interventional radio. So it's like now it's coming up. So when the pelvic bleeding is we can't control, and it's like heavy uncontrollable bleeding. Usually pelvic bleeding is venous bleeding. So we go for interventional radiology. So it's important we are doing it in our NHSL. So be aware about the interventional radiotherapy, interventional radiology. So they do the arterial embolization for these patients. And make sure that you always inform and support the family. So this is one thing we are missing. We do everything and we don't have time, or sometimes we don't bother to go and have a chat with the family. So they are like desperate. They don't have like they don't know what happened and where the patient is going. So always take your time. So here there's a dedicated nurse, but in our setup, I know that we are too busy, but always inform and support the family members. And at the end of the primary survey, do the ample history. I told you, so we have managed the trauma very well, but we have given wrong antibiotic who's allergic to penicillin. So patient will end up with always get an ample history once you finish the primary survey. So I kept on going. Any question? Do you need a break? Any questions up to now? Okay.
No, doctor.
So,
It's clear.
yeah.
No, doctor. It's clear.
Okay. Then once we have done the primary survey, always think of escalating the patient care, whether patient need specialized trauma care or whether he need ICU or ITU care, or whether he need ongoing transfusion. And to begin the secondary survey, patient should be like stabilized, and he should not have critical life-threatening injuries that require urgent interventions. We already discussed the life-threatening during the primary, life-threatening injuries during the primary survey. So we should then and there identify and act for those injuries, and then go for the secondary survey. So again, a summary during the so once we have identified the primary life-threatening injuries and manage. So if there's a necessity to transfer the patient, before transferring, we should assess again as we are assessing the primary survey and make sure that the patient is stable. So these are the components we should assess before transferring the patient once the primary survey is over. An important thing is documentation, and we should mention our monitoring trends and the interventions we have done, and the on investigations. So these are very important when you are transferring the patient. Otherwise, the specialized center may require these details later on. And make sure that your equipments are ready, batteries are checked, oxygens and infusion pumps, and your bag valve mask is functioning. And make sure before transferring the patient that you check these things and kept ready for the retrieval. So once you have completed the primary survey, now it's the secondary survey begins. So it's a like head-to-toe evaluation with complete history and examination, and always reassess the vitals. So the main aim of the secondary survey is to not to miss any injury, and complete assessment of each region of the body to identify any hidden injuries. So we already discussed the 6 life-threatening injuries that should identify during the primary survey. So these are the 8 potential. So during secondary survey, the potential life-threatening injuries we should identify. So these are the potential life-threatening injuries we should identify during the secondary survey. So aortic dissection, thoracic injuries, that is non-massive hemothorax. We discussed the massive hemothorax in the primary survey, and simple pneumothorax, it's tension pneumothorax in the primary survey. Esophageal perforation, diaphragmatic injury, blunt cardiac contusion, plial segment. So I already mentioned that earlier the plial segment was included in the life-threatening injuries during the primary survey, but now it's downgraded to secondary 8 potential injuries. So we do the primary survey, we complete, and we completed the adjuncts of the primary survey and got an ample history, and then decide whether to transfer the patient for the specialized care, or if the patient is stable, we go for the secondary survey. So once the secondary survey is completed, we have to think of further care. So this comes to you who need ICU care. So a trauma patient, following trauma initial management, pre-hospital and emergency department, and then once it is managed, these patients require ICU care. That is severe traumatic injury. There are scores to identify the severity of the trauma. So one is ISS, Injury Severity Score. So there are score systems that calculate the severity. And if the patient is having multi-system organ failure following trauma, or ARDS following major trauma, or following the surgical intervention for the post-operative care. So these are the few groups of patients that require ICU care after trauma management. And so now it's your job. So responsibilities of ICU trauma nurse. So can anybody tell what are your duties? What are your, like, what do you want to perform in the ICU for a trauma patient? Or you can put into the chat box even.
Monitoring.
Yeah, very good.
Relieving pain.
So relieving pain, yeah, that comes under supportive care. Yeah, very good. Okay.
Investigations.
Yeah, investigations. Yeah, you like monitoring include vital parameters plus investigations also. Okay.
And give a fast heartbeat for the patient at one
Yeah,
side.
yeah. Give a hug. Yeah. Matsankata puluwan deenne. Yeah, a fast hug. Yeah, that is the you do the definitive care. So monitoring specific trauma care. So that is more important. That's patient specific treatment we have to continue. As example, if the head trauma patient, what would you do specifically in the ICU? Like you prevent the secondary brain damage, no? You brain protective measures you have to take. What are the measures in specifically you take in the traumatic brain injuries?
Positioning.
Very good. Yeah.
Breathing.
Breathing. But what are the like goals you want to achieve in a head injury patient?
And maintain the proper intracranial pressure.
Yeah, that's like, yeah, to prevent the secondary brain. So already primary brain damage has been occurred. So we sorry?
Prevent hypoxia.
Yeah, very good. Yeah, hypoxia. Yeah, so prevent hypoxia. So basically maintain normoxia, normothermia, normocarbia, normoglycemia, and the intracranial pressure to prevent the raise in the intracranial pressure. So for that one, we keep the if there's no if there's suspicion of the cervical spine, whole bed should be elevated for 30 degrees. So that facilitates the venous drainage of the cerebral venous system. So again, also we look for any like constrictors around the neck, cervical collar we consider. So later we will discuss about the cervical collar and the spinal board. It's important to know. And as you mentioned, yes, to prevent the secondary brain damage. So I want to emphasize that monitoring is, yes, monitoring vital parameters and investigation and specific trauma care. So whether the patient has having traumatic brain injury or cervical spinal injury, abdominal trauma, chest trauma, orthopedic. So specific trauma care. So for the abdominal, you have to measure the urine output or bladder pressure. Or chest trauma patient, again, the vital parameters. And the orthopedic, yeah, you have to measure the peripheral pulse. So like that, you have to specify the specific trauma care according to the individual patient. And as Madhusanka mentioned, it's supportive care, feeding, analgesia, blood sugar, thromboprophylaxis, head up, also prophylaxis, and G. So these supportive care you should you should be given to the patient. So in ICU, it's monitoring both vital parameters and the investigation. The trends are more important than the individual readings. So I think ICU, you maintain a chart which is very important, which reflect the progression of the patient. So monitoring specific trauma care depend on the patient's specific trauma pattern and the supportive care. So this is the fast hug. So you practice every day. So it's like trauma is a systematic. For the trauma, you should have a systematic approach, and in ICU care also, I know you all practice this, so it won't miss anything. So we'll come to a case. So now the trauma assessment, primary survey, adjunct, secondary survey, definitive care we discuss. So before finishing, it's almost, so what's the time in Sri Lanka? Somewhere around
9:25, doctor.
So then boring to that nanny, then I started 8:30. So,
No.
No, sir.
Okay. Okay, then so we'll before wind up, at any time you just feel free to answer. Singaling ari ahanna long ideyata ahanna me ඕන question එකක් ඕන විදිහට raise කරන්න. So then and there you can once you ask a question අහන්න නැතු ප්‍රශ්න අහන්න නැතු ඉන්නවනේ අනිත් අයටත් ඒක උදව්වක්. ඒගොල්ලෝ ওই ප්‍රශ්නේ එක ප්‍රශ්නයක් අහනකින් කීප දෙනෙක්ටම එකෙන් support එක වෙනවා. You ask anything, don't feel shy. Okay, so think that I'm also like your colleague and then ask anything. Feel free to ask anything. Huh? So before in this session, so there's a case, this is a real case. Okay, so I'll give the case. Can anybody like read out the case? Volunteer.
18 years old male, 4 hours back, step chest turn.
Okay, Matsankar, we'll go by line. Okay, so 18-year-old male, 4 hours back. So it's the age. This is the pre-hospital handovering of the patient. So it's 18 years age and time. So in pre-hospital handovering, it's important, the age and the time of the incidents. Okay, then 18-year-old male, 4 hours back, step to left chest, third intercostal space, mid-clavicular line. So this is mechanism of injury. So we discussed the age and the time duration of the injury, and then the mechanism of injury. Is it important?
Yeah.
Yes.
How does it like significant? Why this is significant? So we can prepare, no? So yeah, we can prepare. It's a third intercostal space in the left side. So cardiac injury is possible. So in preparation, this information is very important for the preparation, in hospital preparation. So we can call the cardiothoracic team. So we have to anticipate cardiac tamponade or blunt cardiac injury or penetrating injury. So this is important. So age. So what is the mnemonic? It's admissed, pre-hospital handover, and its age, mechanism of injury, the time of injury, and the mechanism of injury. Okay, and then the mechanism, injury pattern, yes, it's the same as, so, and the signs and symptoms. So saturation 85, severe distress, engorged neck pains, ongoing oozing from the stem. So this is the signs and symptoms. Okay, and the admissed treatment given. So these are the treatment given. So this is very important. So even when you're practicing, you like as a trauma, it should be a sequential and systematic approach you need. You always practice these things So when you are hand over in a patient, trauma patient, always stick to these things. So age of the patient, time, duration, mechanism of injury, very important. So it gives a lot of information for the further preparation of the team. And then the signs and symptoms of the patient and the treatment you have given. Okay. So so what's the whole idea? So after getting these pre-hospital information, so we can prepare. It's a life-threatening chest injury. So can one of you tell what are the life-threatening chest injuries?
Pneumothorax.
Sorry?
Pneumothorax.
Yeah, tension pneumothorax. Yeah, tension pneumothorax. Okay. What are the other things?
Massive hemothorax,
Very good. Massive hemothorax. Okay.
cardiac tamponade,
Very, very good. Cardiac tamponade. Then. So those are the three life-threatening chest injuries. So before coming the patient to the emergency department, you have an idea regarding the injury pattern and what sort of injury you anticipate. So then and there you discuss with the your team colleagues, and even though it's the team leader, you can raise your voice and tell. So I'm suspecting it's a cardiac tamponade. So it's very important to get the details correctly and analyze and then prepare to receive the patient. Okay. So this is the patient. What can you see? What are your observation? Now you are having the patient in your department. Anybody can notice?
Distended neck vein.
extended jugular veins.
Yeah, very good. Yeah. Distended neck veins. Yeah, very good. That's the sign. Okay. So patient is real distress. No? Patient. Okay. So what you can see is Beck's triad, distended neck veins, and patient's blood pressure somewhere around 70, and you can't hear the heart sounds. So what's your diagnosis?
Cardiac tamponade.
Cardiac tamponade. So we confirm it by doing the bedside ultrasound. So fast ultrasound. So we call this E-fast, extended fast. So fast is focus assessment of sonography in trauma. So we do the abdominal windows and the thoracic windows for the hemothorax and the cardiac tamponade. So this is our fast. So this is the heart, surrounding blood, and heart is rarely not contracting. Again, so this is the heart. That's the ventricles, the chambers are collapsed due to blood collected in the pericardium. Yeah, can you see? So obviously heart is not moving because of the blood. Okay, so what we are doing? Ultrasound guided pericardiocentesis. So we got the patient information, pre-hospital information, and we analyzed the patient and identify the injury pattern, and we got prepared, and we are performing the life-saving measures. Even 20-30 ml of blood withdrawal will relieve the patient's symptoms and until we have a definitive cardiothoracic care. So around 100 to 150 cc we have evacuated, and patient completely recovered, and we transferred him to the cardiothoracic unit. And this is the important thing. Once you do the primary survey, always once you finish the primary survey, log roll the patient to see the other side of the injuries. So you are dealing with front chest injuries, but patient can have injuries in the back of his chest. So always do the log roll and adhere to the spinal restriction protocols, and complete examine the patient to identify the other hidden injuries. Okay, so that's all. So this is actually an overview. I don't think I can teach everything in this session, but so this is a rough guide. You have to always be in the emergency department, and then even though you are ICU, ITU colleagues, but always try to hang around the emergency department, and that early information and early experience is very important to continue your care at the ICU or the ITU. Any question? Anything to clarify? Understood? Or like, and so this is the best nursing colleague I ever had. So she's like, we had only 5 or 6 beds. Other than her like bed, she goes to other beds and search for the requirements and do whatever, like discuss with us and inform the patient conditions, and always make sure that we all are happy in the emergency department. So this essence you should always get, and try to learn and try to be happy in your department. Always share knowledge, and then like you can give the best nursing care to the patient. Any queries?